Welcome to the class. Today we begin with our new talk, management of palpitations and cardiac arrhythmias in pregnancy. There can be EMQ on this particular topic. Palpitations are very common in pregnancy and most of them are benign. Almost 50% of cases it is just an ectopic or non-sustained arrhythmia. Most common cardiac complication in pregnancy is arrhythmia. Okay, this you please remember from SBA point of view. The most common cardiac complication in pregnancy is the arrhythmia. Okay, high risk group are the patients who have the pre-existing heart disease, and if there is a prior history of arrhythmia, then there is a 43% chance of recurrence. Okay, do remember that palpitations in pregnancy are usually physiological, but they will require evaluation to exclude the pathological arrhythmias. Okay, there are certain changes, physiological changes, which we have seen multiple times before, but I'll just cover it. There is an increase in cardiac output by around 50%. 10 to 20 beats per minute. There is increase in the heart rate, stroke volume is increased, intrapartum cardiac output is further increased, and postpartum, even the heart rate is increased up to 110. It can happen in the first 48 hours. Okay, so these are the physiological changes which are happening in the pregnancy. Okay, and there are certain variations, normal variations, which you see in the ECG, that also we have discussed yesterday. So normally there is increase in the heart rate, so you'll get the sinus tachycardia. Left axis deviation is also common. Then T wave inversion, which is seen in V1 to V3 and lead 3, that is also normal variant. Then you get a Q waves that is seen in lead 2, lead 3 and AVF, which is also normal variant, and ectopics are seen in 50 to 60% of cases and common and benign. So if you are asked physiologically, among all, what will be common? Ectopics. Okay, around 50 to 60% of cases, that is going to be common. Okay, and if you are asked the pathological arrhythmia, then it will be supraventricular tachycardia. Okay, so uh, these are the things which are happening, and that is why the patient is prone to be prone for the arrhythmias. Okay, so what are the conditions which favor arrhythmias? There is increase in the blood volume, there is increase in the estrogen, and these autonomic and hemodynamic changes predispose the patients to have arrhythmia. So differential diagnosis, it may be physiological, it may be pathological also. Among benign conditions, we can have a sinus tachycardia of pregnancy, exercise or stress-induced tachycardia, or ectopic beats. In pathological, we will have supraventricular tachycardia. That is the most common pathological. Then atrial fibrillation and flutter can be there. There can be ventricular because of anemia, hyperthyroidism, sepsis, hypovolemia, pulmonary embolism, then hypoglycemia, POTS, that is postural orthostatic tachycardia syndrome, pheochromocytoma. These causes which you have to keep in mind. Okay, so these list keep in mind and look for the specific features, and it will help you for the solving the EMQs. Okay, so other causes like psychological, there'll be anxiety, panic situation, then drugs like caffeine, nicotine, salbutamol. Recreational like cocaine, amphetamines will cause tachycardia and arrhythmias and withdrawal of beta blockers. Okay. Then we need to take a detailed history, look for any red flag symptoms like syncope, pre-syncope, etc. If there is a syncope, think of it is going to be a serious arrhythmia. If there is a chest pain, we will think of ischemia. If there is a dyspnea, it may be associated with heart failure or pulmonary embolism. Okay, so palpitations plus syncope we need to evaluate because it may be a serious arrhythmia. Okay, so general examination, systemic examination, cardiovascular system examination, we'll look for murmur, and we will go for the investigation. So when to suspect pathology? If it is associated with syncope, if it is a sustained tachycardia, if there is a known heart disease, if any abnormality on examination and family history of sudden death, think of that this may be a pathological arrhythmias. Okay. So management principle, it is always a multidisciplinary team approach. We have to treat the underlying cause and do not delay the treatment just because the patient is pregnant. And most of the antiarrhythmic drugs are safe in pregnancy. Okay. So if it is a physiological palpitations, just need a reassurance, avoid triggers like caffeine, nicotine, etc., and give the lifestyle advices. However, if the patient it is a pathological arrhythmia, Look for the condition of the patient, whether the patient is stable or unstable. If it is stable, medical therapy will work, and if it is unstable, she will require cardioversion. And remember, cardioversion is safe in all trimesters. Okay, so indications will be hemodynamic instability and severe arrhythmias. Okay, so what are the antiarrhythmic drugs which are used in pregnancy? The first line is a beta blockers. Then adenosine is used in acute supraventricular tachycardias, and adenosine is the preferred drug for supraventricular tachycardias. Okay, then digoxin for rate control. Verapamil is another alternative, and amiodarone to be avoided unless it is life threatening. Okay, so amiodarone is not preferred. Digoxin if for mainly rate control, but for supraventricular tachycardia, adenosine is the preferred drug. Okay, so what are the points which we will keep in mind? The arrhythmias may first appear in the pregnancy, or they may recur if the patient is having previous history. Postpartum risk persist, especially in the first month. Then palpitations in pregnancy are mostly benign. Ectopics are most common findings. Syncope is a red flag symptom. Then ECG changes are often normal variants, and cardioversion is safe in pregnancy, and we need to treat arrhythmia without any delay. Okay, so we need to stratify the risk. Okay, so what are the predictors of arrhythmia? If the patient is having known cardiac disease, there is an increased likelihood of having arrhythmias. Okay, if there are palpitations during the sleep, if the palpitations are at work, there is increased likelihood that these arrhythmias will require further evaluation. Okay, so features reducing the likelihood. If there is a history of panic disorder, if the duration is less than 5 minutes, in that particular case, the likelihood of serious arrhythmias is less. Okay, so the careful history is going to be very, very important. Then which are the high risk group? If the patient is a known case of congenital heart disease, if there is a pre-existing arrhythmia, and a first presentation of cardiac disease in pregnancy. Okay, so structural congenital heart disease, that is the strongest predictor of pathological arrhythmia. Okay, so careful history is going to be very, very important. So look for the frequency, duration, circumstances, whether aggravated by the rest, exertion, whether they are at rest or exertion, then triggers or relieving factor like vagal manures, etc. We need to look for, and careful past history, drugs, family history is required. Okay, so features suggesting arrhythmia. So this particular table, if it is a physiological, it will be fast, regular, okay, and especially on lying down. Occasionally, there can be ectopic, which is described as a thump, and pre-vasovagal symptoms will be there. So these symptoms will suggest it is a physiological. Okay. Then concerning feature will be if it is a fast and irregular rhythm, if it is occurring during sleep or work, syncope, dizziness after the palpitation, associated with chest pain, dyspnea, then family history of sudden death, known cardiac disease, hypertension, headache, sweating, that will point out towards pheochromocytoma. Okay, so syncope after palpitations, so that is also suggestive of arrhythmia and not vasovagal. Okay, so baseline investigations are must. Okay, so especially if you do not have a clear diagnosis, and if the symptoms are persistent, we will go ahead with the investigations. Okay, so basic investigations such as full blood count, thyroid function test, 12 lead ECG. So full blood count will rule out anemia, thyroid function test to rule out thyrotoxicosis, and 12 lead ECG will help in diagnosis of arrhythmias, and it will also be a baseline investigation. Okay, so this table, that same thing what we have discussed, that the feature suggesting the need for echocardiogram in echocardiogram may not be required if we feel that it is a physiological etc. Okay, so the best diagnostic test, if the patient is coming during the symptoms, and if we do the ECG, that is the best for us. Okay, so most of the time the presentation is in between the episodes. Okay, so ECG findings. So what are the abnormal ECG findings which suggest a pathology? This also you should remember, because these findings sometimes may be a part of the history and scenario which is given to you. So presence of delta waves will point to the WPW syndrome. Okay, high voltage complexes plus Q and ST changes will point out towards hypertrophic cardiomyopathy. And if QTC is prolonged for more than 460 milliseconds, that will suggest the long QT syndrome. Okay, so any abnormal ECG, we need to take the cardiology opinion. Then ambulatory ECG monitoring is one of the important thing. So we have to do it for 24 to 72 hours. Generally, in 3 to 24% of cases, it will give you a good diagnosis. And especially if the patient is having frequent symptoms, it is very helpful. And other devices such as event recorder, implantable loop recorder can also be used. Then how to interpret this alter? Okay, if there is a sinus tachycardia and other tests are normal, we can reassure the patient. If there are occasional ectopics, the patient can be given reassurance. But if it is a significant arrhythmias and there are symptoms, we need the patient to refer to the cardiology. For the echocardiography, if there is a suspected structural heart disease, abnormal ECG, significant symptoms, and known cardiac disease. Okay, so it is not required if clearly everything is physiological. Then tachyarrhythmias. What are the different types? It may be sinus tachycardia, where the heart rate is between around 80 to 87 beats per minute, generally seen in the third trimester, and mainly it is the physiological. But we have to differentiate it from POTS, that is postural orthostatic tachycardia syndrome, and inappropriate sinus tachycardia. The management we need to exclude systemic causes, and generally no treatment is required if it is just sinus tachycardia. Then it can be ectopic beats in around more than 50% of cases. It may be atrial or ventricular. Patient may complain that appearance of the misbit sort of feeling. Again, reassure, no treatment is required. The next is supraventricular tachycardia. This is one of the common thing which is asked in the examination with a long scenario. Most common pathological arrhythmia is supraventricular tachycardia. Okay, so it is the most common pathological arrhythmias. Okay, so incidence is around 24 per 1 lakh maternities. Onset is in pregnancy in around 34% of cases, and there are two different types. One is AV nodal re-entry pathway, AV nodal re-entry, and another is the accessory pathway. Okay, so there are two. One is AV nodal re-entry, and another one is through accessory pathway. So these are the two types of supraventricular tachycardia, and the ECG shows short PR interval and the presence of delta waves. Okay, in WPW you will get this short PR interval and the delta waves, so that will diagnose the WPW. So best predictor of arrhythmia is a pre-existing disease. Then most common finding is ectopics. Gold standard investigation is ECG during the symptoms. Most common pathological arrhythmia is supraventricular tachycardia. Holter yield is low, around 3 to 24% of cases. Syncope after palpitation is a red flag, and echo is required to rule out structural disease. Okay, from SBA point of view, most common cause of palpitation is physiological or sinus tachycardia or ectopics. Most common pathological will be SVT. Most important history feature is a syncope. First step is a detailed history, then shockable arrhythmias go for cardioversion, especially when the patient is unstable. Okay. So coming to the management of supraventricular tachycardia. Okay, so most common pathological arrhythmias we have seen, and it is around 24 per 1 lakh maternities. In around 34% of cases, onset is during the pregnancy, and common mechanism is a AVNRT, that is atrioventricular nodal re-entry pathway. Okay, and there is another accessory pathway. So pathophysiology, there are two types, AVNRT and accessory pathway. So AVNRT is the most common. Re-entry circuit is within the AV node plus perinodal tissue. Here, this is what is the pathology for AVNRT, and this is the most common cause for PSVT. Okay, paroxysmal supraventricular tachycardia is mainly because of the AVNRT. Okay, here the re-entry is through the AV node and perinodal tissue. There is another accessory pathway or AVRT. Then conduction bypasses the AV node. There is a faster conduction. ECG feature is a short PR interval. Okay. So in AVNRT, narrow complex tachycardia is seen. In accessory pathway, you get a short PR interval. Okay. So clinical feature will be sudden onset and sudden offset, rapid regular palpitations, may or may not be associated with the syncope, chest pain, and may be associated with the hemodynamic compromise. Okay. So management. First line will be the vehicle manure. Okay, so Valsalva manure is the first line for the management of the SVTs. Okay, if it fails, then IV adenosine is the drug of choice. Success is around 90%, safe in pregnancy. Most of the time, the question is either here or here. Okay, so the first line is a vehicle manure, but if they ask the first line drug, then the IV adenosine. Okay, so alternatives will be verapamil and metoprolol. And if the patient is unstable, then DC cardioversion and it is safe in pregnancy. Prophylaxis, beta blockers. Okay? So avoid routine catheter ablation unless refractory. So first line acute SVT in pregnancy is a vagal manure followed by adenosine. So next type pathological is atrial fibrillation or flutter. The causes are mitral stenosis, structural heart disease, and electrolyte imbalance. So if it is a atrial fibrillation, there will be no P waves and it will be irregular complex. If there is a flutter, you will get a sawtooth pattern. Okay, around 300 beats per minute, there will be rate of the atria beating. Okay, there is increased risk of thromboembolism. So pregnancy itself is already hypercoagulable state. So management, the patient is unstable, go for DC cardioversion. If the patient is stable, achieve the control with flecainide, ibutilidide, and rate control by beta blockers and AV nodal blockers. Okay. Coming to the anticoagulation. So if there is a persistent atrial fibrillation, low molecular weight heparin can be used. It requires MDT planning. Then coming to the ventricular tachycardia. So in ventricular tachycardia, you will get a wide QRS tachycardia, potentially life-threatening and often associated with the structural heart disease. Okay. Types, idiopathic, which is usually benign, and structural disease, ventricular tachycardia, that is high risk of the sudden death. If the patient is unstable, immediate cardioversion is required. If the patient is stable, pharmacological medications such as sotalol and flecainide is required. Prophylaxis is with beta blocker, then amiodarone if needed, and ICD high risk patients. So ventricular tachycardia plus instability, immediate cardioversion, remember from SBA point of view. Next is a long QT syndrome where QT interval is prolonged more than 460 milliseconds. Important clinical factors, pregnancy, the risk is reduced. Postpartum, there is increase in the risk, especially type 2. Management is a continue beta blockers, avoid QT prolonging drugs and correct electrolytes. So drugs to avoid are ondansetron, prochlorperazine, erythromycin, and trimethoprim. Neonatal implication, there is a risk of sudden death and neonatal plus genetic referral is required. Then coming to the bradyarrhythmias, there may be first degree block, which is benign. Second degree block, that is Venkebet's block, usually benign, and there can be complete heart block. It may need pacing. Okay, bradyarrhythmia generally not asked. Okay, management, if the patient is asymptomatic, observe. If the patient is symptomatic, go for pacemaker. Okay, pacing is safe in the pregnancy. So what are the antiarrhythmic drugs which are used in pregnancy and about their safety? Adenosine, beta blockers, digoxin, these are safe. Okay, flecainide likely to be safe. Lignocaine, verapamil are safe. Amiodarone is to be avoided for long term. Okay, so and if you use amiodarone, thyroid plus growth issues are there, so it is avoided. Okay, so amiodarone only for life-threatening arrhythmias. Coming to the management of pre-existing arrhythmia, preconception, risk counseling is required. Optimize the condition, review the drugs, and consider ablation. Antenatally, a review of the medication is required. Growth scan is required if the patient is on beta blockers. Anesthetic plan is required and delivery planning. Intrapartum, vaginal birth is preferred. Continuous monitoring is required and prepared emergency plan. Postpartum, monitor the patient, continue the medication, breastfeeding is advised, and cardiology follow-up is required. Postpartum period is the highest risk period, especially for long QT syndrome. Okay. So most common arrhythmias are supraventricular tachycardias. First step is a vagal manure. Drug of choice is adenosine, atrial fibrillation, anticoagulant with low molecular weight heparin. BT if unstable, go for cardioversion. LQTS, postpartum risk is increased. Amiodarone, avoid long term. and MDT care is essential. Okay. So we have certain EMQs, doctor. Can we try few EMQs?
Yes, sir.
Just
Management of
just hold on, please.
yes.
Yes, doctor, please go ahead. Can you see the slide, doctor?
Yes, sir. Yes, sir.
Yeah, please go
Management
ahead.
of acute tachyarrhythmia in pregnancy. Question.
Yeah.
A 28-year-old primary gravida at 30 weeks presents with sudden onset palpitation. She describes a rapid regular heartbeat that started abruptly while resting. No prior history of cardiac disease. On examination, heart rate is 180, BP stable, ECG showed narrow complex tachycardia. Vagal maneuvers are attempted but failed to terminate episode. Second line will be adenosine.
Yeah. Because it is a diagnosis is a SVT. Okay.
Supraven- Supraventricular.
So it is a classic SVT, narrow complex, regular, sudden onset and offset. So stable patient, vagal maneuver. If fails, go for adenosine. Safe in pregnancy, 90% is a success rate. Okay. Next.
A 34-year-old gravida to paravan at 28 weeks presents with palpitation and breathlessness. ECG shows absent P waves and irregular rhythm. She has known rheumatic mitral stenosis. She is hemodynamically stable.
So AF plus structural heart disease, high risk of embolism. So pregnancy is a hypercoagulable state. So anticoagulation is essential. Low molecular weight is safest option in pregnancy. Next. Yeah.
A 30-year-old woman at 32 weeks presents with palpitation and dizziness. ECG shows a wide complex tachycardia. She becomes hypotensive and confused. This is unstable ventricular tachycardia. Go for
What it will be? Wide complex tachycardia. She becomes hypotensive and confused.
cardioversion because it is unstable. Can go
Yes,
for
patient is
cardioversion.
unstable, so DC cardioversion. So ventricular tachycardia plus hemodynamic instability, emergency. So go for immediate cardioversion, which is safe in pregnancy. Okay, now we have few SBAs. Okay.
Pregnant woman reports skipped beats but is otherwise asymptomatic. Halter shows occasional ectopics. What is the management? A. Adenosine. B. Beta blocker. C. Reassurance. D. Cardioversion. E. Flecainide. C. Reassurance because ectopics are a common finding in
More
pregnancy.
than 50% cases, they are benign, no treatment is required. Next.
Which is the most common pathological arrhythmia in pregnancy? A. Atrial fibrillation. B. Ventricular tachycardia. C. SVT. D. Bradycardia. E. AV block. C. SVT.
Correct. Next.
First line treatment for stable SVT in pregnancy. A. Adenosine. B. Verapamil. C. Vagal manure. D. Beta blocker. E. Cardio version. It is C. Vagal manure.
Correct. And if they ask first line drug, then it will be adenosine.
Adenosine.
Okay. Next.
Drug of choice if vagal manure fails in SVT, it is B. Adenosine.
Correct. Correct. Same question. Next.
Which ECG features suggest Wolff-Parkinson-White syndrome? Prolonged QT, short PR with the delta wave, absent P waves, sawtooth pattern, wide QRS. It is B. Short PR with delta wave.
Correct. Correct. So there is an accessory pathway, I guess, here in WPW.
Most
Next.
important red flag in palpitation is A. Palpitation at rest, palpitation on lying down, syncope, short duration, caffeine intake. It is C. Syncope after palpitation.
Yes. Palpitation with syncope. Next.
Best anticoagulant for atrial fibrillation pregnancy. Warfarin, aspirin, low molecular weight heparin, DOAC, clopidogrel. It is C. Low molecular weight heparin.
So especially atrial fibrillation, LMWH is indicated to prevent the thromboembolism. Okay. Next.
Management of unstable ventricular tachycardia. A. Adenosine. B. Verapamil. C. Cardioversion. D. Digoxin. E. Observation. C. Cardioversion.
Correct. Next.
Which drug should be avoided long term in pregnancy? A. Digoxin. B. Beta blocker. C. Adenosine. D. Amiodarone. E. Verapamil. It is D. Amiodarone.
Correct. Because of the thyroid effect. Okay. So amiodarone. Next.
When is the risk of arrhythmia highest in the long QT syndrome? A. First trimester. B. Second trimester. Third trimester. Intrapartum. Postpartum. E. Postpartum.
Yes, there is a postpartum increase in this long QT syndrome. Okay. So SVT is the most common. So vagal manure and adenosine. Then atrial fibrillation, go for anticoagulation.
Anticoagulation.
VT unstable, go for cardioversion.
Cardioversion.
Ectopics, reassurance.
Version.
Syncope is a red flag. Long QT syndrome, postpartum risk is increased. Amiodarone, avoid long term. Okay, so that finishes the talk article discussion on palpitations in pregnancy. Thank you.